now we have to move forward in our webinar with a presentation by Dr. Philip Onyebujoh. He is a clinical immunologist born in Nigeria, and he has worked in global health for 30 years and is an infectious disease physician and a researcher with special emphasis on tuberculosis and HIV/AIDS. Recently, he worked as senior technical advisor for strategy and policy to a director for Africa Center for Disease Control and Prevention. He has authors and co-authors numerous peer-reviewed publications, including several WHO guidelines and policy documents. Dr. Onyebujoh, you have a microphone. Let me quickly read the questions you will have to address. So the main question addressed to Dr. Onyebujoh are: 1, how is the Watch on African Infectious Disease organized? 2nd, what is the nature of the infrastructure? And 3rd, how does the Africa Center for Disease Control operates? You have a microphone.
Thank you very much. Let me try and load my screen. Share the screen. Can you confirm that you can see my slides?
Yes, it's okay.
Okay. Great. Thank you very much. My thanks goes to the organizers for this incredibly exciting webinar. I'm going to try and keep to the time allocated. There's been some, I think, differences between the questions I received and what the conveners just talked about. I'll share it with you in a minute. So before we get into the actual issues, just to give you a background on what the burden that we're dealing with, and this is by no means an incredibly accurate data of what's happening in COVID so far. This is from WHO, the African region, dated October 13th this year. We have approximately over 12 million cases in the continent with more than 256,000 deaths. The population of people who have been fully vaccinated, utilizing the denominator of people who can be vaccinated, is about 22.7%, or 265 million. Partially vaccinated is 28.5%, or above 333 million. This is absolutely abysmal if we're going to be improving and optimizing control of this pandemic. The organizers' questions that I have received are as follows. How is the Watch on African Infectious Diseases organized? Are there African autonomous common responses to infectious diseases, and how experiences and expertise and resources are shared in that respect? And the third question is, what kind of resilience do African societies have in front of the COVID-19 pandemic? What lessons can be learned from this experience to build more resilient public health systems in Africa and enhance their preparedness for future pandemics? Dealing with the first issue, I would like to interpret that as an update on infectious disease surveillance in Africa. And that runs through the context of detection, prevention, mitigation, and response. Unfortunately, my French is not good enough to appreciate the incredible presentation by Professor Raoul, but I picked up a couple, and I see we're going to be converging at some point. I suppose that would be good for emphasis. But essentially, the widespread, if you like, democratization of genomic sequencing platforms has improved our capacities all over the world, including Africa, to be able to detect and sequence viruses of different origins. with respect to COVID-19, we've now been able to detect and track variants, especially those that are coming from outside the continent. So it now gives you a fairly good idea of what is indigenous to the continent and what is coming out of outside the continent. There's been extensive, as a result of this pandemic, extensive strengthening of capacities to detect pathogens of public health concerns, Ebola viral disease, COVID, dengue, Lassa, etc. It's all happening. Monkeypox, it's all happening very quickly. We're almost saying that a pandemic is an incredible stimulus towards development within the scientific programs within health systems in various African countries. It's optimized that component very quickly. So we've been able to facilitate rapid detection and to be able to allow the capacity to detect to be utilized in real time. We've now deployed connected diagnostics, which is employing enhanced electronic modalities to enhance turnaround time for diagnostic platforms. So you actually, as opposed to waiting 2-3 days to get the data, you're getting the data as it is processed, particularly in countries that use GeneXpert, molecular diagnostic platforms, as mentioned by Professor Didier. There's now the linkages within those kinds of platforms makes it actually easier to access data, access the capacities of the diagnostic tool, and respond appropriately to the data being received. One area that is important that links to the whole concept of surveillance is an improvement in International Health Regulation 2005 reporting by the African Union member states. And the signatories are obliged to notify WHO on the emergence of diseases of pandemic or epidemic potential as listed within the International Health Regulations documentation. I would want to pay particular emphasis, and this is not because of my bias, having worked at the Africa CDC, but the Africa CDC has developed the kind of framework that we're looking for to enable the sharing of information, the facilitation of capacities to actually bring to bear on emerging and re-emerging infectious diseases. They set up what they call the Regional Collaborating Centers in 2017, which is been set up in each of the 5 main economic sub-regions of Africa, North, East, South, Central. And then within that complex is the Regional Integrated Surveillance and Laboratory Network, which has been linked to national public health institutions. What do these do? They facilitate the networking of laboratory capacitation, such that if, for instance, Cameroon detects X and does not have the capacity to confirm it, and Ghana has the capacity to confirm it, that network within that region enables that to happen almost seamlessly. That was the design, that was the hope. There's been also an improvement in notification systems, especially utilizing surveillance from print and electronic media and digital analysis. This would trigger the response from the various country ministries of health and then facilitate epidemiological teams to investigate. We are aware of what is going on at the moment in Uganda with the most recent outbreak of Ebola viral disease. Uganda notified WHO within 48 hours of detecting it, and WHO and the Africa CDC have sent epidemiologists to assist the government in responding it and in containing and managing the problem. That's the essence of early notification and response. WHO has supported background disease surveillance through commissioning of prevalence studies to determine disease burden. And I'll refer to this later on in my summation regarding the fact that some of the diseases have now, by virtue of the singular focus on COVID, some diseases have now gone back to their maybe way beyond their pre-COVID days. Tuberculosis death rate WHO has just announced has almost gone back by about 10 years. So the gains have thwarted by just a singular focus on COVID. To just give you some exemplars, research and development platforms that is active in Africa include the Africa Center of Excellence for Genomics and Infectious Diseases, based in southern Nigeria, the Center for Epidemic Response and Innovation in South Africa, Africa's CDC's Pathogen Genomic Intelligence Initiative, which I was part in developing, which is based in Ethiopia with the Africa CDC, but is linked through several African countries where capacitation for molecular diagnostics and genomic sequencing has now been developed through the efforts of the Africa CDC with funding from the Bill and Melinda Gates Foundation. The KwaZulu-Natal Research and Innovation and Sequencing Platform in South Africa has been critical. Now, in terms of targeted testing, in other words, which group will give us the biggest yields, we've looked at, and this is specific to Africa, truckers, long distance truckers. Now, there's been recently, in the last 10 to 15 years, a huge swath of internally displaced persons moving across different bandwidths, different parts of Africa. Given the porosity of African borders, you can imagine what that means in terms of disease transmission. So tracking those would be critical. Patients who are vulnerable by virtue of immune deficiencies would be also another target, and that includes HIV positive patients, TB patients. Malaria is also a potential susceptibility, vulnerability within that particular scope. Now, WHO, with the emergence and the community spread of COVID-19, have targeted specific variants, and they've developed two major variants, variants of concern and variants of interest. The thinking is that in areas where these have been identified, that should facilitate the focus and the target for surveillance to appropriately improve yield. The second question relates to Africa's unique responses to infectious diseases. And this question has two segments to it. But before I talk about the response, I'll talk about the context. And the context we're talking about is the context of fragmented, uncoordinated activities to detect infectious diseases. The health systems in Africa do not have the optimal capacity to be able to facilitate the requisite preparedness or response. Inadequate skills, physical resources from chronic underfunding, poor planning. I mean, you can name it, the whole shopping list of problems. Africa's health security, by virtue of poor planning, inadequate capacities, health systems issues, have been imperiled, resulting in major community-based transmission of infectious pathogens. And then in responding specifically to the focus of this webinar, the absence of a unified policy framework on infectious disease control has resulted in suboptimal detection, prevention, mitigation, and response. In other words, do we need an umbrella organization to facilitate a coordinated response, or do we need a system where member states will now take specific responsibilities based on guidelines provided by, say, an institution like the Africa Union, Africa CDC, WHO, the Africa region, etc., to implement a successful policy that guides the countries in terms of response appropriately. There's been in Africa an incredible and significant urban-rural divide, which results in incomplete information. In spite of the explosion in information technology, being able to capture information at the district level, has been almost impossible. So community impact is usually the last thing to be heard. The interventions seem to end either at the tertiary or at the secondary levels. Beyond that, it's a guess game, which is unfortunate. I mentioned chronic underfunding, but the response, and I want to congratulate the Africa Centers for Disease Control and Prevention for what it's done. It's been the main driver, jointly with WHO, for COVID-19 related responses. And they set up a series of, if you like, programs, mechanisms to be able to bring to fore critical interventions. The Africa Task Force for Coronavirus, AFCOR, is a major one. The Partnership to Accelerate COVID-19 Testing in Africa facilitated access to costly testing, which would have been impossible without that level of intervention. Looking at supply chain issues, the Africa CDC also formed the African Medical Supplies Platform. And then finally, the Africa Vaccines Acquisition Task Team, which worked hand in hand with COVAX to facilitate access to vaccines and then plan and plot how to ensure that the requisite vaccine would, would be acquired by several member states within Africa. It was mentioned in Professor Didier's presentation about the issues around sovereignty in terms of interventions, therapeutic interventions, vaccinology, etc. I'll deal with that towards the end. Other institutions of importance in Africa include the South African National Bioinformatics Institute based in Cape Town in South Africa. They've been doing excellent work in genomics, sequencing the various samples within that particular country. The Kenya Medical Research Institute is another one, and the Nigerian Center for Disease Control and Prevention in Abuja. In Ghana is the Noguchi Memorial Institute for Medical Research. The Institute Pasteurs in Africa have been incredible in what they've done, and I can't thank them enough for providing that kind of backbone that is necessary towards improving the capacity to control these kinds of diseases. I want to congratulate my colleague Amadou Sarr in Dakar for what he's done at the Institute Pasteur. And then National Institute of Biomedical Research as well has been one of the major institutions that facilitated the kind of response we're thinking about. Sorry. Right, so the second part of that question is how are the experiences and expertise and resources shared? As I said at the beginning, the capacity to share information and resources has been seen as being contextually important and critical to the development of a major response or optimized response for not just COVID, but for a variety of emerging and re-emerging infectious pathogens. So here we reflect on how the experiences and that information and resources shared have been utilized in optimizing the control of COVID in Africa. So, as I said, as I alluded to earlier on, the African Union and the Africa CDC developed programs to facilitate sharing of information at sub-regional levels through supported public health institutions. There's also been the desire, and that has also been achieved through the African Union, of harmonizing the regulatory programs by sub-regions to provide access to regulations in countries with weak or non-existent capacities. Working with the African Union, they've now developed the African Medicines Agency, which is based in Rwanda. Now, what is the essence of this? What's the importance of this? Professor Didier mentioned the need for development of clinical research to facilitate efficacy and safety determinations of new interventions. Now, that data needs to be regulated for use in the public space. Most countries in Africa do not have strong or functional regulatory programs. And so what is being promoted, what is being supported, what is being thought about is to have regulatory authorities by sub-regions. In other words, utilizing the economic sub-regions within Africa, SADC, COMESA, ECOWAS, look at the strongest regulatory authority in those regions and allow the member states of those sub-regions, rather, to agree to use that to facilitate the registration of a vaccine, a diagnostic, whatever it is. Now, that is going to ease the problems of lack of standardization, etc. So that's an important thing that needs to be said. Genomic sequencing, as I mentioned, is being shared within the continent and internationally through standard databases, GSAID, what Professor Christian Happy in his center in Ede in southern Nigeria, the African Centers for Excellence for Genomics of Infectious Diseases, signed agreements. The development of the regional collaborating centers required signatories amongst member states in that particular sub-region, our agreement to be able to share information, which was the essence of creating if you like, a hub for member states to relate to. Several centers of excellence and hubs exist in Africa, which would be wonderful in supporting the implementation of guidelines for the control of infectious diseases. I mentioned AFCOR, I mentioned the other issues, the other components therein. The third question relates to the kind of resilience African societies have shown. And I think that Professor Didier's, from my very halting French, dealt with this quite effectively. But I would want to add a couple of things. It might be a repetition from what he said. The thinking throughout has been that Africans have not been testing properly. So consequently, the data we're getting from case loading is wrong. Data we're getting from morbidity and mortality is wrong. But then, if it was so staggeringly wrong, the deaths that we are recording related to the deaths in the West would have been largely different. Africa has the second lowest mortality rate from COVID-19 at this point in time. And some thoughts around why this is happening, what is driving the resilience. It includes natural immunity due to repeated bouts of infection. So immunologically, exposure to an incredible plethora or array of infectious diseases creates the capacity to facilitate innate and natural immune responses, which would dampen down, ameliorate the potential impact of an infectious disease when it comes home. So, but one thing that hasn't been appropriately understood is that when the concept of lockdown was entertained, most African countries facilitated the implementation of early lockdowns, beautifully, almost to the point that the Chinese government at the moment, Professor Hall, you will agree with me, have implemented, and that resulted very quickly in a diminution of community transmission. Nobody's talking about that, but that is happening. This is my own personal observation based on the work that I've been doing. So, and that has led to diminished number of cases, particularly given the very poor health infrastructure. Africa also has a fairly young population compared to the Americas and Asia. The median age in Africa is 18. In Americas and Asia, 30 to 35. So that would, support or complement that resilience. There's also been, we know that comorbidities with non-communicable disease, hypertension, diabetes, etc., would facilitate more severe COVID outcomes. Comparatively, we've got low prevalence of non-communicable comorbidities compared to other populations globally. The socioeconomic support has been a bottom-up approach through community-based and private sector initiatives, which has been extremely laudable. Sorry, thank you. So the second part of that question is what lessons can be learned from this experience to build more resilient public health systems in Africa and enhance their preparedness for future pandemics. That has to do with development of appropriate health informatics. As I said, this is important. If you look at what's happening in the West, vaccine hesitancy has been the result of several issues. One is inadequate information, the availability of electronic platforms that allows people to create disinformation, and so people would shun the appropriate interventions. Then there isn't a one-all strategy. One should look at a One Health approach, which looks at the environment, animal health, and human health as a package, given the fact that we know that the future pandemics would almost invariably be zoonotic, coming from animals. They are probably going to be airborne. So they require the capacity to integrate these components appropriately. There should be improved research and development for countermeasures. So Africans should develop some element of capabilities to manufacture their own vaccine therapeutics and diagnostics. And we mentioned the utilization of herbal medicinal sources. That should be looked into as a complement to what is happening at the moment. There's a need for acute health system strengthening to improve the capacities of our systems to respond to outbreaks and strengthening awareness and mechanisms for endemic disease control. I mentioned TB earlier on. We should begin to ring fence funding and seek support from global financial institutions for endemic and pandemic relief. That is critical because given the fact that at the moment, most African member states have not even reached the Global Fund United Nations prescription of the utilization of 15% of GDP towards health and welfare. There should be an elevation of the quality and quantity of public health responses. National government should be involved in protecting public services and not simply wait for handouts coming from outside the continent. There should be an articulation of response to protect one's citizenry. Skilled human resources for R&D for vaccines should be developed either jointly or through a platform that sees African member states sharing this knowledge or sharing these capacities. South Africa is very highly advanced. The Institute Pasteurs in Africa are doing a lot of work. The MRCs are doing a lot of work. So all these are potential sources for that level of assistance. There should be an optimization of childhood immunization coverage to minimize vaccine preventable illnesses. With the issues around COVID and the singular focus, capacities for even providing childhood immunizations in Africa declined very significantly from 2019 to date. That is a warning that should be looked at properly. And then there should be a need to develop an African health security and health intelligence program supported through private and public partnerships. By health intelligence, I mean the documentation of events, actions, responses for countries to look at and facilitate and optimize their own mitigation approaches. So this is my penultimate slide. Policy recommendations for future pandemics. One, thinking through this, would like to promote and document African-based solutions and control strategies, including research into herbal medicines and traditional healing practices. I think that's important. We should open it up and see what goes. If they are open to randomized control clinical trials or appropriate evaluations for efficacy and safety, then we need that knowledge to make firm decisions. African member states should increase their investment in health and disease, as I mentioned earlier on. We should now expand our genomic surveillance throughout the continent, especially in areas with recorded high densities of transmission of other viruses. So, for instance, what's going on in Uganda should prompt, a deeper surveillance to see if there are other things happening. I read in Nature 2 days ago that respiratory syncytial virus has now fused with influenza A. And that is if that happens and is seen in Africa, it will almost be unimaginable. So we need proactive surveillance, more active surveillance than the passive surveillance program that African member states have actually utilized. As I mentioned, there needs to be an urgent revision of international health regulations to respond to the current outbreaks and outbreaks going forward. We need to promote the establishment of biotechnology hubs for the manufacturing of therapeutic vaccines and diagnostics in each of our sub-regions. We also need to enhance our digital ecosystem to enable fast access to real-time information and health interventions. We are suggesting that African member states should coordinate their actions with the rest of the world to achieve optimized outcomes for disease control. This is development of standards, so that you're not working in a vacuum. You work with partners. This becomes critically important. A human resource exchange program between between the sub-regions and the EU member states would help in addressing the skilling gaps, the gaps of skills that we're seeing. We need to accelerate critical training of manpower through international collaborations and technology transfers, and then conduct gap analysis to have a clearer view of the skills inventory. And then we need to seek to promote clear political approval for pandemic control as is necessary. So my final slide, we need to support efforts of community-based organizations, and that is critical because there's not very much happening at that level. District healthcare levels and district programs have been very poorly funded, very poorly looked after. So should we be looking at a bottoms-up approach, especially in terms of policy formulation and implementation? I don't know. That's a question that I would love to have somebody discuss. Expand our engagement with academia and centers of excellence will be critical. But one thing I've been thinking about for some time, having worked in this area myself, is to develop biobanking facilities with accurately linked data on these samples, such that when we're dealing with the next pandemic or a newer version of a previous pandemic, we'll have a source to develop vaccine and therapeutic targets. It's critically important. We need to have a modality for appropriate translation of research outputs to policy and practice. And that is not easy. And as I was discussing with Professor Ali earlier on, it's a challenge for us because as scientists we develop evidence, but translating that evidence into meaningful culture and context-related practice in different parts of Africa is really challenging and hasn't been done to scale, to the best of my knowledge. We need to be able to adopt current global cooperation strategies rather than mandates and political agendas. And that would include things like standardizing evidence-based public health social measures to suppress viral transmission, establishing mechanisms of shared information amongst the member states, and then getting member states to adhere when the IHR is updated appropriately so that early warnings would impact on the outcomes of future pandemics, ongoing pandemics, etc. Do not forget that the thinking of the world at the moment is that COVID-19 is over. So most of the strategies that were in place are over. They're not there. Nothing is happening. Now, the emergence of new variants might create a problem, especially within health systems in Africa, which have been weakened, not only by this pandemic, but by chronic underfunding as well. So we need to watch it and watch this space. I thank you very much for the opportunity to present this. Thank you.
Chairman, we can't hear you.
Okay. All right. Thank you. Thank you very much, dear doctor, for your very instructive presentations. I give a microphone to the discussant, Martial Zebelinga. Martial, you have a microphone.
Thank you so much, Chairman. Thank you, Dr. Onyebujoh, for your presentation. It was a comprehensive presentation in the framework of what we asked you, particularly. And you were on the side, I would say, on the health system and how the institutions play in mitigating the effect of the pandemic, and my question, my first question for you will be to question how you make how you interpret the data. My question is somehow not tricky, it's provocative, let us say, because if we listen to Professor Raoult, if we listen to what you said in terms of data, I'm not sure that we could have the same appreciation on the importance of COVID-19. So I want to push you on that side first. Would you have called it a pandemic, you yourself? If not, is the status of COVID-19 such a priority in the African context? And if you say, compared to malaria, etc., etc., and if you don't have the same appreciation that everybody gave to the pandemic, what lesson could you draw from that? What lessons could you draw from the wrong expectations, and that everybody seems to be obvious that African would barely die from COVID-19, etc., etc. So for you, was it an African priority? Was it a pandemic? Was it an African priority? And if not, because everybody said it was a pandemic and it would be something very tragedy, an African tragedy, what lesson can be learned from that in the idea and the perspective of building an African sovereignty? This is my first question. I'm not sure I will have many questions because I'm afraid we ran out of time. So you have the microphone. Thank you.
Thank you very much. That's Professor Benninger. That's a wonderful set of complex questions, which is thought-provoking, if to say the very least. The World Health Organization is the authority globally for the pronouncement of defining the nature of outbreaks, disease outbreaks. And there are set criteria for doing that. The World Health utilized that appropriately. But the question that you're asking, and which is what I am really interested in discussing with you, is the resilience shown in Africa, the data that we're seeing from Africa. Does it truly justify the thinking as the pandemic emerged that Africa is going to suffer? And that's what I dealt with in one of the slides. And I said, one, data is dependent on who is collecting. It is dependent on the sources. Now, WHO collects data from 47 member states in Africa through the Ministries of Health reporting to WHO. So the data is as good as each country is able to report. And I made an example. I said, during the outbreak of Ebola viral disease in 2014 to 2016, it started in Guinea. Guinea did not report as understood and as obliged under the International Health Regulations 2005. And so information lacking, neighboring countries were affected by virtue of not really knowing what is happening. So that piece is critical. Now, the data that we have from Africa, at best, informed estimates. And my initial, when I started off, I said that the thinking now is that COVID is over. And because of that, the money's going in to supporting agencies responsible for actually actively surveilling for disease prevalence and disease burden has plummeted. And the data I showed was from WHO, which was the best possible estimate. But having said that, it does not mean that the COVID-19 is not a pandemic. That it did not affect Africa the way it was predicted to by virtue of Africa's very poor health systems, poor capacity, absence of R&D for vaccines, etc., was not because Africa wasn't affected. It was because of factors that we're still researching. The data seem to suggest the following. One is that Africans of Negroid origin living close to the equator have a fairly, if you like, decreased morbidity and mortality within the COVID-19 exposure. That's what the thinking is. Nobody knows exactly why. The second, which I mentioned, was that the incredible exposure to a wide variety of infections may have increased our immunity to a very significant degree. And that might have impacted on the kind of data that we're seeing relative to other countries. I mean, we have the second lowest mortality in the world. So that may explain it. The third thing that I mentioned earlier on is the fact that we have a younger population in Africa. And younger means more robust immunity compared to the West. And so you're more likely to have more severe outcomes from any infectious disease, even with the poor issues around African health systems. But one thing that is not being talked about, I don't know whether you caught that when I mentioned it, is that Africa appropriately implemented the non-therapeutic interventions very rapidly. Masking, social distancing. The lockdown was almost as severe as what happened and what is happening in China at the moment. And that impacted very significantly on community transmission. So that the kind of deaths where the West was anticipating did not happen. But nobody's talking about that. It's taken for granted that, oh no, nothing happened. The African nations were not able to implement, the kind of non-therapeutic measures that in Abuja here, I can tell you when masking was implemented at such a level that if you're in a car, they stopped you and said, "Where's your mask?" That was how serious it was. So to a very large extent, the debate around the West, where people said, "Oh, masking is not essential. We don't need it. This is all some thoughts from some government agency trying to rule the world," was not seen that way because Africans accepted that. So I'll stop here. I don't want to be too political about it.
Okay, I think that it's as you can imagine, and you got the idea. It's a very crucial issue because from what we draw from that question, we can even ask if vaccine was the good solution, like Olivier Eldi, who is a research worker, who is in the audience. He said one question was vaccines the good solution? And other people ask, even I think Olivier is still asking if really we need to have one solution for everybody. But above that, I think the epistemological model that we use, somehow when we talk about health sovereignty, I think we have to question the epistemology. We use the word resilience. Resilience means that we suppose that we are to be affected by the disease. So when we use that word, the word resilience, we suppose that if it's a global pandemic, if I don't know which institutions says we should be touched, then we will be touched. And we start thinking about why we are not touched by this and that, you see? So I think that maybe, I don't know if you have another reflection on that, but maybe I give you maybe a conclusion on that point, and we'll go forward, not to take the time of Dr. CDB or Mrs. Peyu.
I agree. This is not the end of it. This is open to research, open to finding out, so that we have more genuine and more germane information. So it's not, I'm not saying that this is the closure of it. It's open, yes.
Okay. Okay, thank you. Thank you. Chairman, Professor Hall, you have the microphone.
Okay, okay, thank you very much. So I have one very quick question, and then I will take the questions from the public. I have a sample from Olivier Heidi.
Yeah.
So my question is, as you know, there were attempts from the World Health Organization to correct figures from Africa under the presupposition that they were very systematically underestimated. So as an expert in this field, I just want to know from you, how do you react to that attempt of a World Health Organization to cook new figures that will fit with the expectation of African disaster?
Thank you very much, Paul. It's just, why am I laughing? Because this has been, I've had this discussion at several levels, and there's no conclusion to it. You see, COVID-19 was a completely new disease to the world. Nobody had any idea. So there were lots of different, suppositions. At the beginning, even WHO, even the United States CDC did not believe that it was airborne. WHO did not. So there were lots of issues around what is the disease. There were issues around how to even detect it, diagnose it. And so the initial SWOT of diagnostics were not too good. So it overrepresented initially, and then there was new detection capacities came in, molecular diagnostics improved, all that. So it's been a learning curve. WHO was serving the public viewpoint, knowing that most African countries did not have the wherewithal to detect it appropriately. So it worked on the basis of the fact that there was poor detection, poor documentation, poor mortality reporting, etc., and decided that this probably was a need to begin to deal with this. Unfortunately, the African member states did not respond appropriately. They did not say very much about what they did. And so the thinking was that, well, whatever was being said was right. So I'm not going to go into whether it was wrong or right or whatever it is, but suffice it to say that the mortality we're seeing, the severity of disease we're seeing in Africa answers your question. If the data was so off the charts, as WHO had indicated, more people would have died. And you don't need to document, to have appropriate documentation when people start dying. Death is death, and you see it happen. We didn't have as many severe cases. We didn't have as many hospitalizations, even amongst the cohort detected. So there was clearly something that was happening that was uniquely African. So that's why I said to Professor Belin that this is open to more research and more thinking. I'll stop there.
Thank you.
Okay, let's take some questions from the audience. First, Olivier asked 3 questions, so I will take the middle one, which is bigger. It has been demonstrated that the pandemic affects the world differently. Most cases of death were observed in the Western countries, and particularly in the rich environment. Consequently, do you think that the way to fight the disease should be unique, or should we try to find out some tailor-made solutions according to the different populations?
Chairman, please.
Yes.
Yeah, we have Olivier within the participants. Maybe can we give him 1 minute or 2 because I already transmitted that question. So maybe could we give him 1 minute or 2 to express something he has to say, because he's also a research worker.
Oh, okay, 2 minutes, okay.
Okay. Olivier,
all right. Olivier, I have microphone.
Olivier
okay.
Edi. Can Dispoina give him the I think I can give him the microphone.
Okay, go ahead. That he's online?
Okay. Yes, it should be. Olivier, you should be online. Okay. Put on the microphone, Olivier. Okay, it's been done. Now we're listening to you. Okay, Olivier, we're listening to you. We can't hear you.
I can simply respond. Okay, yes.
Okay, it's good.
Can you hear me?
Yes, it's good.
You can hear me.
Nice.
I can't hear you, that's why.
We can hear you. We hear you.
Okay, so thank you very much for putting this program together. And I think that the level of presentation is very high and I really enjoy it. I have only one quick question since I have only 2 minutes. It has been demonstrated and it has been said also by the two speakers already that the pandemic did affect the world differently. And the question that I have is, what is really behind the difference that we do observe between, for instance, the Africa, since we are discussing how to do in Africa, and the rest of the world? And also, there's a component that nobody has spoken of so far, is the genetic. So I was just wondering, in your research and also based on your experience, how will you assess, or how will you factor in the genetic component or component in the resistance towards COVID-19, especially for the African population?
Thank you very much, Olivia. I don't know whether you joined us a little bit later, but I did mention. Can you hear me? I don't know how to do. I did mention in my presentation. That African population and the continent has an incredibly wide array of genetic diversity. That the exposure to an incredible array of multiple infections has altered our immunological capacity to respond to a host of diseases far more than a person who lives in a more, if you like, clean environment. I'm using that word in quotes. And to a very large extent, that has directed and optimized African innate responses. And the question that Professor Hall mentioned, whether the peculiarity or the uniqueness of the African response warrants, a different or unique intervention, is actually an important question. And the answer is that we don't really know. Should we be looking at context-specific, host-specific interventions that would have a different efficacy outcomes? We don't know that, but which is why forums like this is important, because we want to be able to promote an African response, an African approach, an African contextual intervention that takes into consideration our genetics, our culture, our exposure, and our capabilities to accommodate those kinds of interventions as well. So it's all important. But the underlying message here should be there is a need for more concise, more in-depth research and development focus to look at all these components, including herbal interventions, how they fit into the fray of all this. I'll stop there.